Hello, I'm Kent Comfort with tallgrasseconomics.org. For today's podcast, we're going to have Charlene Harrington. Charlene is a gerontologist and professor of sociology and nursing at the University of California in San Francisco. She's been in this important field since 1980. She was elected to the American Academy of Nursing and the National Academies of Medicine, and her research has focused on virtually every aspect of the long-term care industry. She's a participant in international nursing home research with colleagues in 6 countries. Charlene has testified before Congress and has written more than 250 articles and books, including Healthcare Policy, Crisis and Reform in the U.S. Healthcare Delivery System, which is now in its 5th edition. Please welcome Charlene Harrington. Greetings, Charlene. Welcome to the tallgrasseconomics.org podcast. Thank you very much for joining us today.
Well, thank you for inviting me.
You're most welcome. I'm curious, you have a tremendous background and history in the field of the nursing home industry. I'm curious how you got started in it.
Mm-hmm. Well, I started out as I went to KU and graduated in nursing. And so I've been a nurse for many years, and I went back and got my doctorate in sociology, and then I went to work for the state of California and ended up being in charge of regulating nursing homes back in the 70s. And so nursing homes were really problematic then as they are now. So since then, I've been trying to understand what the problems are and why we can't resolve the quality issues. So that's how I got started as a regulator, and seeing how challenging it is to try to regulate an industry that's mostly for profit.
Really interesting. So from that time to today, would you say we've improved any or gotten worse, or nothing has changed? What's your thoughts there?
Well, I wouldn't say that we've improved a lot. You know, some people argue that there are improvements, but we are still having the same basic problems of trying to regulate nursing homes, and the same problems with the for-profit side of the industry. And when I wouldn't say that things are a lot better. They are a little better. When I first started out, the staffing was even worse than it is now.
Oh,
And so one of the things I did when I was a researcher, when I joined the University of California, San Francisco faculty, I studied nursing home staffing. And I'm very excited because we have a new article that's coming out. Going to be
okay.
coming out.
Excellent.
And it says it's a group of nurses calling on CMS to mandate adequate professional nurse staffing standards for nursing homes. And we have been fighting for this for 40 years. It is shocking. I was on the Institute of Medicine committee to look at nursing homes in 1985. And at that time, we made many suggestions for how to reform nursing homes and how to improve the regulation of nursing homes. And that was published in 1986. And that was picked up by Congress, and the report was adopted almost entirely as it was laid out by Congress in the 1987 Nursing Home Reform Act. And in that act, it required nursing homes to do comprehensive assessments, and it set out standards for what nursing homes should do in terms of, ensuring that people don't have pressure ulcers and weight loss and all these quality problems. So it formed the basis of the current regulatory system nationally for all nursing homes. But in that uh, Institute of Medicine group, the last issue on the agenda was the staffing. And I argued that we had to have a minimum staffing standard. And a lot of people on the committee agreed with me, but they refused to put it in the recommendations because they thought it would cost too much money. And that way they were concerned that the Congress would not, it could kill the whole report if Congress thought it was going to be too expensive. So they unfortunately left that out, and we've been suffering ever since.
Indeed.
Because one of the main ways that nursing homes make their money is by cutting staffing and keeping staffing to the bone. And this article that I'm talking about that's just going to be coming out, we point out that RNs are only 15% of the nursing staffing. So the public is very misled because people are going into nursing homes primarily for the nurse staffing.
Sure.
And they're not getting it. They don't realize that most of the work is being done by nursing assistants with very little training, basically 2 weeks of training. And the residents are so sick, they have many problems. And over the years, the resident care needs have gotten much worse. They're more like hospital patients in some ways. And yet we haven't staffed to appropriately to take care of the residents.
That's frightening, and it's so important that this kind of information be more widely published. Your paper there, is it possible that that would be available for a reprint in the Tallgrass Economics blog?
Well, it hasn't, it will come out in March, but sure,
Okay.
definitely I'll send it.
Wonderful.
We point out that the research during this COVID period has just emphasized that
Yes.
the first study I did in California, we did it last spring, and we showed that nursing homes that had RN staffing below what we call 45 minutes per resident per day, which
Wow.
includes all the administrative nurses, were 2 times more likely to have COVID than the nursing homes that had adequate staffing. And so nursing homes are hiring licensed practical nurses because they're at least $10 an hour cheaper. And they don't want to pay for the registered nurses. So that's why it's shocking because in fact, most nursing homes don't have 24-hour RN on duty.
Really?
So that's why people get sick in the nursing home and they end up going to the hospital because they don't have trained staff there that can take care of them. And that's why the infection control has been so poor. And there's another paper that just came out that showed that just increasing the RN staffing by 24 minutes per resident per day reduced the infection rate and the death rate by about 26%. So we know of all the things to prevent COVID, one of the most important things is having adequate RNs and adequate total staffing. And yet that's not been adopted, during this whole time period. Instead of the government telling these nursing homes to increase their staffing, they haven't done it. They let them drop staffing.
I think we probably have a pretty good idea why that is. The lobbying group is so powerful in that environment, and the legislature believes what they say, I'm sure, pretty much whole cloth. And it's logical that they would fight that because they're serving the shareholder, not the patient, aren't they?
Absolutely. And when we've tried to get the staffing increased in California and other states, as well as at the federal level. The industry, they're very powerful. They come in and argue that they can possibly do that because they're already almost going broke.
Yes.
They
Right.
don't have enough money, and they couldn't hire more nurses, and they aren't out there, which is totally not true because the fact is they're not paying them sufficiently.
Right. Right. You probably know of some very good models of nursing home facilities that are being run as they should be. Can you give a profile description of those cases?
Well, there are most of the nursing homes that have adequate staffing and good quality are nonprofit facilities and government. And we've shown in our research that these are the homes that were less likely to get COVID infections and to do much better during this pandemic. We have another new paper that's under review, and it shows that the worst nursing homes that had the highest mortality rates were the large nursing home chains.
Sure. Sure.
And the for-profit companies, and ones that had the worst staffing because of the economics of trying to, keep their costs low.
You've studied operating statements of nursing homes, I'm sure, extensively. So what percent of the operating cost is personnel?
Well, in California, we found that the nurse staffing, of course, you have to have adequate dietary needs. You have to have therapists, social workers, and other types of services, but nursing is your primary service. And some nursing homes have only 35% of the money is going to nursing staffing.
Wow.
They're pulling out the money into all kinds of related businesses. And most nursing homes now, of course, have two companies. It's not just one nursing home. It's the operating company and the property company.
Yes.
And then they set up management companies, pharmacy, staffing, therapy, supply companies, many other related companies. We have one nursing home chain in California that has about 80 nursing homes, and that owner has 170 companies related to those 80 nursing homes.
Is that right?
Yeah. Yeah. So they use these companies and to do business with their own companies, and then take out excess profits.
Sure.
When they charge, they charge excessive rents, they charge huge overheads for their management and all kinds of related things.
Just milk it, in other words.
Yeah. So by the end of each quarter or each year, they're actually showing a loss on the books because they've pulled out so much money into these other companies.
I get it. I get it. Good model if you can get by with it.
Yes, and it's legal. We haven't.
Yeah.
We don't have adequate reporting requirements, and we don't have any prohibitions against doing that.
That's really unfortunate. This is really important information, Charlotte. I really appreciate your sharing this. The future prognosis for the industry, is it operating at capacity right now? Is it considered to be a growth field where there's going to be a lot more facilities constructed and so forth? What are your?
I hope not. Over the past 20 or 30 years, there's actually, the aging population has increased quite a lot. But the occupancy rates in nursing homes have gone down over almost a 30-year time period.
Oh, they have.
Yes, and they're not going up. And since the pandemic started, the operating, the occupancy rates have dropped from around 84%, 85% down to 75%. And I think they should drop much lower, because we have people in nursing homes that don't need to be there. But the nursing homes, they have, in order to make money, they have to do two things. They have to keep their costs for staffing low, and they have to keep their beds full.
Yes.
So they need to have a high occupancy rate. And so unless they get a troublesome patient, they don't want to release the patient, and if they can keep them. Now, if the patient has any behavioral problems, or if they're too much work or other things, the nursing homes, if they're on Medicaid, and if the nursing home thinks they can fill that bed with a resident on Medicare, which pays more money, then they'll try to discharge them. But otherwise, they're keeping people in that they could rehabilitate and send home, but they have no incentive to do that. So that's a real problem.
What would be, of course, COVID sort of is an obvious reason for some population decline.
Right.
But aside from that, what would be the reason for that? Because as you say, the population is aging. And in fact, I'm curious about what the typical entry point age-wise is for when someone becomes a resident in a nursing home. Has that changed over the years that you've worked in this industry?
Yes, I think it's gone up. I think the typical would be about 85.
Okay. All right.
But people don't want to go in nursing homes.
No.
I mean, they're such unpleasant places.
Right.
And they're institutional in structure. Most of them are quite old. The buildings are old. The rooms are dingy, and they have 2, 3, and 4 people stuffed into a room, which you can hardly walk between the beds in some of these facilities.
Oh my.
And that's to make money, So
Sure.
the crowding has been a terrible problem during the COVID pandemic, because if one patient gets the virus, then it spreads like wildfire. It spreads to all their roommates, because they're sharing the bathroom, they're sharing the rooms, and there's no place to isolate the patient that has the COVID infection. So that has been a major factor. And we also see that the average nursing home is about 100 beds. So they're big and institutional, and sometimes they have 30 or 40 patients on one unit. And so they're not a pleasant place to live. It's like being in a third-rate hospital. And so we know that the not having single rooms has contributed to the spread of COVID. And in Norway, I've done some work in Norway, and Norway required every nursing home in the country to rebuild a few years ago, and they all have single rooms. They're all beautiful buildings, and many of them are designed properly in what we call clusters. So you have 8 or 10 or 12 patients in a area, and each one has
a specific building. How do they do that?
what?
Okay, are these like 8? Are they different buildings, or are they?
No, they're like a unit. And some of them are different buildings, but you can build up and have each unit just have 8 or 12 patients on the unit with single rooms, single bathrooms. Then each of the areas, they have their own kitchen, they have their own dining room and living room. So the people live as a group. And we know that small facilities were much less likely to get COVID.
Sure.
So
Or anything else. Yes.
the large buildings, you have so many workers coming in and out. So you have so much exposure, not only the nursing staff, but the dietary, the laundry, all the different group workers coming in and out. So your exposure to infection is much greater. So one of the things we're calling for is a rebuilding of all the nursing homes and to downsize them. That, let's have them all have single rooms and build in cluster units and keep the, not have high rises. So keep the total size of the facilities much smaller, because we don't need all the facilities we have now. The reason, another reason we have so many people in nursing homes is that we don't have enough home and community-based services. And that's because the Medicare doesn't pay for those services. Medicare, it will pay for home health care, but that's like short term.
Oh, excuse me. Yeah.
Okay. It doesn't pay for the longer term care at home. So only Medicaid pays for that. So a lot of states haven't developed enough of these home care services to keep people at home. So then that's why they end up in a nursing home when they could stay at home.
Sure. So, yeah, these problems run broad and deep, don't they? The Norway model, are they private? Are they privately owned or government owned?
So that's the beauty in Norway. All of Scandinavia has this kind of model. It's a much more advanced, sophisticated, and better care system.
Okay.
But in Norway, what they do is all of the nursing homes are owned, the buildings and the property are owned by the cities. And mostly they're run by the city too.
Okay.
So they're local government owned and run. But they have made contracts with a few nonprofits and for-profits companies. And the good thing is that when some of these for-profit companies behave badly, they could just cancel the contract and kick them out. Yeah. Whereas here, all the nursing for-profit companies own the buildings and the property. So if you try to kick out one of these owners, then they just say, okay, well, we're going to throw the patients out on the street.
Right.
And so they kind of hold the government hostage because there's, it would be problematic to find new places for them.
Okay, now you made me think of another thing, Charlotte. I recall a few decades back that nursing homes commonly were owned by counties and cities. So,
Yes.
So these municipalities somehow decided we don't want to be in this business anymore, didn't they?
Yes, they got rid of them, and it was the biggest mistake. It's part of the ideology that has been perpetrated that the private sector can do everything better.
Oh, listen, yes, you can apply, we could have the same conversation about private prisons. It's exactly the same problem. Yes.
And it was a terrible mistake because we know that the government facilities, the few we have left, which is only about 6% of the nursing homes, they have, better paying jobs. They have a stable workforce. They invest in their staff because their workers, work there for years.
Sure.
And they just have much better care than the for-profit companies. They have turnover rates of like 50–60% in the for-profit companies because they don't want a stable workforce. They underpay them so badly
Right.
because they want to bring in new people and keep them at the very bottom pay scale.
I'm not aware of any examples of successful private enterprise operations of critical social services. There's been lots of attempts to do this in a lot of different venues, and I don't know of any that have actually saved money and delivered a better level of service.
But there are some very fancy high-end for-profit companies that cater to very wealthy, but they're making money too. But most of the better homes are the nonprofit and the government facilities. And I think the public just doesn't know that. They don't realize that that now we have the real estate people and the private equity companies are all investing in nursing homes, and they have no expertise and no commitment to providing decent nursing home care for the most part. They're in it strictly for the money that they can make off their property and off of the operating home.
That seems to be the case, yes. And that's part of what we're doing here today is we're trying to get more information out to the public about exactly this. And so we'll be, broadcasting what we're doing here today as widely as we can.
Yeah.
Yeah, it's very important information. So how would you summarize here what we've covered today? What do you see going forward? Because it's got to be, after all the years you've committed to this field, to see it in this kind of condition after this point can't be very satisfying.
No, we knew it was bad, but I think the whole thing just exploded with the pandemic. And we need to reform nursing homes from top to bottom. We have to try to get the worst owners out of the business because some of them are just terrible. And we have to regulate the financial side like a utility so that, we put limits on the profits and the administrative costs.
Sure.
And we have to regulate the staffing, how much staffing they have to have and what kind of qualifications. So we need a top to bottom overhaul. So that's what I've been working with advocacy groups, and we're trying to push that with the new Biden administration.
Great.
Let's look at the whole industry and just redo what we're doing in terms of the oversight.
I just had a thought, maybe this is where having a 78-year-old president is a really good idea.
I think, yes. Right. Well, that's exactly the problem, because you've hit it, is that most politicians never can see themselves in a nursing home. And most of them have enough money that they can hire people and never, like Ronald Reagan, when he got sick, he never had to go to a nursing home.
Sure.
But in Norway, when you talk to politicians, they say, we want it to be nice because we expect that when we get old, if we get sick, we might have to go there.
Exactly.
So they want a different kind of thing. Or they can visualize that their grandparents or grandparents have to go there. But we can't do that here because we're in total denial about getting old and having ever need long-term care.
That's well said. That's a really important point right there. It sure is. And most of us do not have occasion to come into contact with this industry at all until we have a family member that happens to have to go there. And then we are shocked at what we see. You hear it all the time, but there's not a common voice.
Yes.
And so you're doing such important work. I really, really appreciate what you're doing. And I would like to for us to keep in contact with you and maybe have you as a guest again, because I think we've just scratched the surface here today, but we've gone for a while, and we want to give you back the rest of your day. Deeply appreciate your taking the time here, Charlotte, to be with.
It's a pleasure. Thank you.
You're most welcome.